Hi, everyone. My name is Hamara Osman. I'm the VP of Research, Public Policy and Programs at Muscular Dystrophy Canada, and I'm really, really happy to share that today we have an excellent webinar on SBMA, the Canadian guidelines, and what does this really mean for you. And I'm really pleased to have Dr. Carrie Schellenberg moderate and chair today's webinar. So I'll pass it over to you, Dr. Schellenberg.
Thanks so much, Hamira. I'm delighted to be here. Thank you so much for organizing this. And I'm here together with two of my co-presenters and two of my research partners. One is Dr. Malcolm King, who is the medical director for the Saskatchewan Center for Patient-Oriented Research and one of the leads of the Powasquisquan Indigenous Health Research Group here at the University of Saskatchewan, and Dr. Jerry Pfeffer, who is a neurogeneticist in the University of Calgary. And so they will be helping to present some of this information a little bit later. But I will begin. I should tell you that once we have finished speaking, we're going to have a section for question and answer. So please do feel free to think of your questions, write them in the chat, and then we'll definitely have time to chat about those questions later. So I'm going to start with presenting some of our work and with the guidelines. I have had multiple relationships with commercial interests, but the two that are relevant are that we received Saskatchewan Health Foundation funding for these guideline development processes, and also for Muscular Dystrophy Canada for the guideline publication. So we'll talk about why we felt we needed to do Canadian guidelines, what these guidelines mean for people living with SBMA, and discuss some of our ongoing ventures and endeavors to promote awareness. So first off, what is spinal bulbar muscular atrophy? So this is also known as Kennedy's disease. It's an X-linked condition. So men get the condition, but women carry the gene, and they may get symptoms also to a lesser degree. It's due to an androgen receptor gene mutation on the X chromosome. Onset is later in life by age 30 plus, and there's slow progression over decades. There's no treatment. So at this point, management is symptomatic, and we treat symptoms as they arise. So the predominant symptoms is the dysfunction of the motor system. So with limb weakness, this typically begins in the legs and then spreads to involve the arms as well. It's preceded, though, by tremor and cramps, and also fasciculations, little muscle twitches. People have difficulty with speech, swallow, facial weakness, excess saliva, and what we call perioral fasciculations. So small little muscle twitches around the mouth are very common. Very late in life, people can develop problems with their breathing as well. And we'll talk about all these things in more detail later. But what's becoming increasingly recognized, we didn't know this years ago when I started my neurology residency and fellowship, is that there can be multi-system effects of SBMA. So it can affect things like liver, and it can affect heart, and it can affect bone, and it can affect some of the sensory nerves. So again, all of these new findings needed to be addressed. So when we started noticing the very high prevalence of SBMA, or Kennedy's disease, in Saskatchewan and the Western Prairie provinces, we developed a research group, and I've introduced two of the people here. The other is Dr. Alexandra King, who is the Cameco chair for the Indigenous Health Research Group at the University of Saskatchewan, Powasquisquan. And so Dr. King and Professor Malcolm King developed a community guiding circle. So this is comprised of people with lived experience and elder knowledge holder and people with lived experience, as well as researchers. And this group, and particularly the men with lived experience, are able to give guidance with respect to what research we do with SBMA and make sure that it progresses in a good way. And so what we heard from our community guiding circle is that we just need more awareness. People were unfamiliar with this condition, and healthcare providers were unfamiliar with this condition. And it leads to problems like misdiagnosis or misattribution of symptoms to other problems. It really became evident that people wanted more research and more awareness. And one of the ways to do that was to start with Canadian guidelines. So guidelines mean that we, as healthcare providers, come up with a list of recommendations that lead to best care, that help address the symptoms that people experience. And there wasn't a previous guideline in Canada. There was only one actually in the whole world, and it was from France. And it was great, but it was a little bit older, and it didn't address some of the things that we now know to be important, like symptoms in carriers and sensory problems and some of these non-motor issues that we've discussed. And it also didn't address the significance for Indigenous people. So we felt we needed something in Canada to help address this. And so this is the paper that we're talking about, the best practice recommendations. This was published in CMAJ in September of 2025, and we published it as open access. Thanks again to Muscular Dystrophy Canada for supporting that. So it's open access, meaning that you can Google this and you will find the full paper with all the recommendations. It's easily accessible and free for everybody. You don't need to be part of a university and have a special login in order to get this. As we talked about, the goal of the guidelines really was to provide healthcare professionals with up-to-date information. And so this was, we thought, relevant for lots of different types of specialists, family physicians, allied health. The main goal is that we want to improve the lived experience for people with SBMA and increase the awareness. And sometimes in Canada and other places, if you can say, this is the standard of care, it can provide that benchmark, and people can use that to advocate for better services in their own communities to be able to meet those guidelines, to meet the national guidelines. And so we went through a variety of steps, and this included having a multidisciplinary team, essentially, Canadian experts. And then we went through this process that you can see here. I'm not going to read these steps out because we'll go through them in a little bit of detail, but I do want to highlight that this process included input from the larger community, physicians, allied health, patients, carriers, the community guiding circle. We really wanted to make sure that this was representative for what people needed. And so we were very careful to have a large scale feedback process. So we collected experts from across Canada in various fields, and this included everybody from neurologists, neurogeneticists, physiatrists. Physiatrists are also known as rehabilitation medicine specialists, respirology, cardiology, endocrinology, rural family medicine, the Pewaskisquan group, and a resident learner. And the first thing we did was a needs assessment. We surveyed 34 healthcare professionals across Canada from various specialties, some who had been in practice for many years, over 20 years, so a wealth of experience. And we asked them to determine what they thought the most important topics for inclusion would be. And then this list was refined by the working group in Pewaskisquan. And so you see that we came up with these topics here on the right. Again, I'm not going to read through them because we're going to talk through that in detail as we go along. So I felt like this little guy over here sometimes with this mountain of literature to review. But basically, our resident and a research librarian searched the medical literature, and we went through the databases to come up with the abstracts and come up with the published articles to help guide this. We reviewed the articles, we created tables and charts, and drafted recommendations based on what we found. And so once we had done this, we asked for review from the working group, and we got good feedback from everybody. And then once we were happy with this, we sent it to the larger group, so external feedback. So we asked people who weren't involved in the process to be a second set of eyes. And so that included doctors across Canada, allied health, patients, female carriers, the community guidance circle, and we even sent this to some folks outside of Canada for a really well-rounded group of feedback. And so in our publication, I'm going to show you this nice infographic. I really like it because it outlines all the major areas that we targeted. And it shows you here the geographic distribution, that the highest known prevalence actually in the entire world is within people who identify as Indigenous in Saskatchewan. And then we also know from both some publications based on our research and anecdotal experience that Alberta and Manitoba also have very high numbers. And so Dr. Pfeffer will talk a little bit about this later. So when you look at the actual publication, you'll see that we have this very large table of recommendations with supportive backgrounds. So we have a few paragraphs for each topic where we talk about why we said what we said. And for example, here you see that we write that for testing and genetic counseling, that the diagnosis is made when we have this expanded CAG repeat number in the androgen receptor gene. That's exactly what we were talking about earlier on that X chromosome. And here we know that the certainty of evidence is very high. This has been very scientifically proven in research and in the lab. But we also say things like formal genetic counseling should include the range of onset and symptoms and how it's transmitted and the risk for family members. And we really believe that. So we said it was a strong recommendation. But when we say that the certainty of evidence is low, I don't want you to think that that's because we don't really believe in this recommendation. We really do. It's just that it hasn't scientifically been studied. No one has looked at people and randomized them into two groups saying that we're going to give genetic counseling to this group and not genetic counseling to this group. When we came up with the recommendations, we used this grade process, and I'm not going to go into it in detail, but it really allows us physicians and authors of the guideline to be able to make strong recommendations that we think are really important for patients without having the clinical trials necessarily to always back it up, even though we know it's best practice, because sometimes we can't do trials for a particular recommendation. So for the genetic testing and counseling, the problem with the androgen receptor gene is this area of what's called genetic repeats, so CAG repeats. And when we test people for Kennedy's disease, what we're looking for is this repeat in the androgen receptor gene. And sometimes people ask me, well, what's my repeat number? And the reason some people care about this is because sometimes the longer repeats are associated with earlier onset. And we know this in the literature, but how those people progress over time is unclear. We think that it's probably associated with more severe disease, but how it progresses is a little less clear. But we certainly know that the more repeats people have, the earlier onset. Some people asked us, well, should we use testosterone as a diagnostic marker to see if people might be more likely to have SBMA? But it's not useful because the majority of people with SBMA have hormone levels within the normal ranges. Um, Limb symptoms are one of the things that people are most interested in knowing about. And unfortunately, there isn't a way to give back strength. But what we do try to do is find ways to maintain independence, maximize safety, and assess for various pieces of equipment that might be helpful. Bracing, walkers, things in the home, home assessments. And so we work really closely with our community resources and physical therapy to help achieve that. Cramps can be a very common and distressing symptom. And so we try to combat this with hydration. We know that if people are dehydrated, the cramps are going to be a lot worse. We try to use things like stretching, and we can use medications if necessary, but we try not to. First, we try these conservative measures. Same thing for tremor. A lot of people have a very mild tremor. You can use medications like propranolol, but I typically don't because it has side effects too. And I only do if it really is interfering with function, which is almost never. Fasciculations are those little muscle twitches, those ripples under the skin. They really don't need any treatment. They're not painful and they don't damage the muscle. But people notice them, and so they sometimes ask me about them. Another thing is sensory symptoms. Numb feet is very common. It can be because Kennedy's disease is associated with a higher likelihood of having diabetes, and that can cause neuropathy. But Kennedy's itself can also cause problems with the sensory nerve. So Kennedy's can cause some numbness in the feet as well. And that can lead to imbalance and falls. So we want to be careful that we're addressing these things. A lot of people ask me about exercise, and it's a tricky one because there are studies, but they're small. There's limited evidence, and they sometimes conflict with each other. So our position is that exercise shouldn't be discouraged. It has beneficial effects simply beyond muscle, so cardiovascular, mood, weight control, etc. So people with Kennedy should exercise, but it should be individually tailored. We want to avoid excessive fatigue and avoid pain and avoid people feeling more weak. We don't really understand the cardiac symptoms very well, but we know they can occur. We don't, so prevalence, meaning how common it is, and significance, we don't really know. There are some small studies that show that there can be heart rhythm disturbances. So this is possible. It's very rarely life-threatening, but it can be. And this one rhythm disturbance, Brugada syndrome, we think happens in about 12% of people. But way more people have small changes on their ECG, over 50%, over half of people. And so this has led to us referring everybody to a cardiologist for ECG, Holter, echo, and then tests as needed in future as per their cardiologist. We want the cardiologists involved because some of these changes can be pretty subtle. And I need help in order to know how to manage these changes. So one thing that's important is that if people pass out suddenly and without reason, that can be a sign of heart rhythm disturbance. And so if that were the case, you would want to tell your doctor immediately so that you could make sure that your heart is getting checked. Respiratory symptoms typically are mild and occur much later in the condition. And so because of that reduced lung muscle strength, then sometimes it's difficult to cough things out if one were to aspirate on food or saliva. So people can have aspiration pneumonia and possibly respiratory failure later in life. So we want to check breathing every year. And if there's a problem, we use airway clearance equipment. So that's like a cough assist device. And that can help increase cough strength to get the gunk out. We monitor for obstructive sleep apnea. And sometimes if that's there or if the respiratory function is lower, then we use Non-invasive ventilation. You may have heard of CPAP that people use for obstructive sleep apnea. Well, BiPAP is very similar, and we use that too. Laryngospasm can happen quite frequently. This is when people are unable to get air in or out for a period of time. And it's really anxiety provoking when you can't get air in or out. And it's really common. It happens in up to half of people with SBMA. And so we make sure that we tell our patients about this. It's so common. We even have a handout just to say, okay, look, it will pass. It won't kill you, but you do need to try to breathe very calmly. Um, um, Try to relax, and it passes, but it's very difficult to do. It's very very distressing. Um, we know that because that androgen receptor has is dysfunctional, then there can be related symptoms of enlarged breast tissue, reduced fertility, testicular atrophy, some sexual dysfunction, and lower urinary tract symptoms. So difficult to pass urine. There can also be things that are indirectly related to androgens. So we know that a lot of people, almost everyone, has some degree of fatty liver. So it's called non-alcoholic fatty liver disease, and also high cholesterol, diabetes or prediabetes, and bone mineral density can be involved. We don't really know how best to manage this. This is an area of active study, but we are suggesting that people see their family doctors or endocrinologists or other physicians to try to monitor, to try to check regularly for some of these issues. We don't suggest supplementing with testosterone. We know that in disease models, testosterone makes symptoms worse. So we're very careful to not suggest that. Speech and swallow can be affected. Nasal speech is very common. There isn't a specific treatment for this, but people can work with the speech language pathologist to try to utilize ways of being more understandable. Speech exercises aren't helpful. Um, Excess saliva is rare, but if it happens, then we can use some drops to help that. And we want to be assessing swallowing function. Most people don't need a feeding tube. Some do very late in the condition. But we want to make sure that we're monitoring for weight and nutrition and swallowing function so people can continue to swallow safely as long as possible. This is a tough disease to deal with, and we know that we need to be attentive to things like anxiety and depression and make sure that we're connecting with local supports. We also want to make sure that we're ensuring that families and caregivers and community have support as well. Female carriers might develop some milder version of SBMA later in life. We don't have a lot of information about this, but we do know that if symptoms develop, they're usually things like cramps and tremor and just mild weakness. The treatment strategies are very similar as for men, and this is an area of active study. We know that because there's so many areas involved, there needs to be a big team. And so we suggest following up with a multidisciplinary team every year or as needed. And virtual care can certainly be an option if people live further away. Our clinic, for example, sees people all over Saskatchewan. It's important to remember that a large number of people in Western Canada who have SBMA are Indigenous, and we want to make sure that we are proceeding with care in respectful ways. And I'm not going to spend a lot of time on this slide, even though it's such an important slide, because Dr. King is going to talk about this and has a section dedicated to this, and I wish to defer to him for discussion on this. We know that raising awareness is important, and we want these guidelines to be available to a large number of people. And so we're trying to do talks and education days. And, I even did a podcast, which was well outside my comfort zone. But we're working with Muscular Dystrophy Canada also to develop patient-facing materials. And so what I mean by that is have an information sheet that people can have who are living with the condition that might be relevant for them, and to have checklists for the clinic to make sure that everybody's getting the care that they need, and have specific things dedicated to our healthcare workers and in other non-physician allied health care workers, so that we're making sure that everybody has the information that they need. So with that, I've gone a little beyond my time, a few minutes beyond my time. I don't want to take any more time. And so without further ado, I'm going to hand over the mic to Dr. Malcolm King, who I've introduced earlier, who is going to discuss some considerations for Indigenous people.
Yes, thank you very much, Dr. Schellenberg. And Dr. Jerry Pfeffer, if you could show that first slide for me. Um, and this is part of what I usually include for teaching of medical students and other health learners, because I think it's not well known, even in Western Canada, and certainly in most of Canada. This slide is obtained from the most recent census in Canada, the 2021 census. And those of you who do follow these things will realize that 5% of the Canadian population self-identifies as Indigenous. That's 1.8 million people at the time, majority of whom are First Nations, but there's also a lot of Métis and Inuit in that. The red pies on the pie charts show the percentage of Indigenous people by different provinces and territories. And you can see Saskatchewan, where Dr. Schellenberg has her clinic, has about 17% in self-identified Indigenous people. Manitoba has 18%, and Alberta has around 7%. Up in the north, the territories, Nunavut, which is mostly Inuit, actually has 86%, but very small overall numbers. And you can see down here in Ontario and Quebec, the numbers are much lower, but the absolute numbers reach actually the biggest number in Ontario. Now, one reason for bringing this out is that even if we weren't talking about a genetically related disease with amplification, one would expect in Saskatchewan, that other things being equal, that 15 to 20% of any patient population that you study would have the particular condition or disease. But with Kennedy's disease, the work from Dr. Schellenberg and Dr. Pfeffer and others has demonstrated that the disease is greatly amplified in people who identify as either Cree or Soto, which is another word for Anishinaabe, who are from the prairies of Canada. And we know anecdotally that there also are incidences of Kennedy's disease in Cree Anishinaabe people in Manitoba and northwestern Ontario as well, where that hasn't been studied yet. So, should only people in this part of Canada, the Central Prairies, be interested? No, because Indigenous people migrate. And a lot of this has been already proven to be a founder effect some 200 or 300 years ago. But of course, there's a great deal of uncertainty. But anyway, a number of generations back. And There are people from the prairies who end up in Vancouver, in Toronto, in Ottawa, Montreal, all across the country. And the other thing about Indigenous people is that not everyone is visibly Indigenous. I am not visibly Indigenous, yet I am First Nations. My mother came from Switzerland, and I probably look more like she did than my father, who was very visibly First Nations. And so when I go to a medical clinic, a doctor's office, if I don't actually say that I'm Indigenous, then probably the health professional there would not even think of it. And yet, this is important for Kennedy's disease because of this amplification of perhaps as much as 100 times the rate in Cree and Anishinaabe people in Saskatchewan. So it's important anyway. I won't go on and on. I could probably spend the whole half hour on this, but I wanted to just alert everyone to the fact that you have to realize that SBMA does occur in Canada at higher rates than it does in most other places in the world. It is particularly true of the central prairies in Canada, but it can likely be found almost anywhere in the country, and that because it involves Indigenous people, I think it's important that and as Dr. Schellenberg has said, that Indigenous people and their considerations need to be taken into account. And so I'd just like to finish by saying I want to give a shout out to our community guiding circle of Indigenous men with lived experience with Kennedy's disease. And we have some very active advocates for the disease amongst those people who take part, who've given good advice. They're at different stages of their disease, and I think all of us have found their advice to be very helpful. So I'll pass it now on to Dr. Jerry Pfeffer to continue.
Thank you very much. Yeah, it's a real pleasure to be able to present today. Thank you very much to Muscular Dystrophy Canada for hosting this. And thanks, Dr. Schellenberg and Dr. King. To introduce myself to everybody here, I'm Jerry Pfeffer. I'm a neurologist and clinician researcher at the University of Calgary and have been collaborating together with Dr. Schellenberg, Dr. Malcolm King, and Dr. Alexandra King in our extended team for many years to try and learn more about SBMA. So today I'm going to, in 10 minutes or less, talk a little bit about our research progress so far in SBMA work and give you a bit of a summary of some of the work in progress and hopefully tell you a little bit about some future discoveries. So firstly, we've talked quite a bit about this already, but we know, thanks to some work we did now several years ago, that there is what's referred to as a founder effect in the Indigenous communities of Western Canada. And this is mainly in people of the Cree First Nations and Saulteaux First Nations, but also Métis people. And about 83% of SBMA patients in neuromuscular clinics are Indigenous in Western Canada. So as Dr. Kim was saying, That's well out of proportion to what we expect based on the population. And our study suggests that the Soto First Nation in particular seems to have an orders of magnitude higher prevalence than other populations, something that requires further study. Now, we say repeatedly that this is likely to be an underestimate because the way that our study was done, it did not allow us to fully ascertain all the cases in the province. Nonetheless, the results we came up with were still much higher than has been reported in any other population. So for anybody who's interested in learning more about this work, the publication, which is openly accessible, is indicated here by a QR code. And people who know me know how much I love QR codes. We've done some additional work since then. This was a survey of the molecular diagnostic lab at Calgary. So the lab in Calgary does the diagnostic testing for Alberta, Saskatchewan, and Northwest Territories. So all of the testing that comes through, that is ordered clinically, comes through this lab here in Calgary. Surveying results over a 5.5-year period indicated that there is a high incidence case rate for SBMA. Let me put these numbers into perspective for you. The numbers we're getting for Alberta, 0.089 per 100,000 or 1.62 per 100,000 for Saskatchewan. These are similar to the numbers we would expect for the total number of cases in the entire population. But these are just the number of new cases being identified in a 5.5-year period. So it indicates that there is a very high rate of new cases being discovered. We think as we repeat this survey, and we do plan to repeat it in about another 5 years, just for comparison to see, does our number of incident cases even go higher than this as we increase our knowledge about SBMA and let people know that there's a high prevalence in Indigenous communities. And again, those interested in the publication can find a link to it, also open access from this QR code. And of course, Dr. Schellenberg spoke at length about this, but here's a link to the article that you can use for the SBMA clinical practice guidelines published in both official languages and supported by Saskatchewan Health Authority and Muscular Dystrophy Canada. So I'll spend a little bit of time telling you about some work in progress and some of the things that you can expect in the future from our team. And this includes, well, I won't read them because I'm going to go through these one by one. But we have a guidelines implementation project that's being led by Dr. Schellenberg. And basically, the reason that this is being done is because once you have guidelines, that's great, but then you want to make sure that they're implemented in a way that is beneficial for people. Is it feasible? Are there limitations? We've pursued a study in which there has been Indigenous community input from the Community Guiding Circle, with whom we've collaborated for years to get community input on the Indigenous health perspective and includes people with lived experience. We have done a Delphi consensus approach, including physicians who are closely involved with the care of people affected by SBMA. And finally, conducted surveys collecting data from healthcare providers and people with lived experience, which may even include some people on the call today. So for people who participated in that, thank you. Dr. Schellenberg and Dr. Alexandra King are also leading a photo voice project. And this is a project that is highlighting the lived experience of people who have SBMA. And This is based on a methodology with which Dr. Schellenberg already has some previous experience from a publication looking at patients with ALS. And the basic premise is that people submit an image that they believe represents something important about their experience with the disease. And then they participate in interviews and sharing circles. And through qualitative research and Indigenous health research analyses, we come up with a way of representing what people's lived experience is. And in particular, talking about what may be unique about the Indigenous population, given that it's been unknown until recently that there was such a high prevalence. And this is work supported by a grant from Muscular Dystrophy Canada, for which we're very grateful. We are doing some work to further clinically characterize SBMA in Western Canada. So this is work that's being done through two CIHR grants. So a CIHR project grant led by our team. The people on this call will recruit up to 100 participants with SBMA and collect clinical data as well as their clinical investigation data and give us a really comprehensive picture about what might be similar or different about the clinical progress of SBMA in our population compared to other populations. And we also have a partnership with the Canadian Neuromuscular Disease Registry. This is their new logo, and that's through a CIHR data management grant obtained by Dr. Amin and Dr. Hodgkinson. And this will look to develop registries for diseases of particular importance to the Canadian population, and SBMA was selected as one of these. And this is a really important project because it's another method for us to collect detailed data about the clinical picture and gives us the potential in the future to have international collaboration as well. We're also doing additional study about the genetic origins of SBMA. So the first study that I had shown you had looked at a haplotype or a shared region of genetic material, mostly shared among people reporting Cree or Saulteaux ancestry. And a second haplotype or shared region of genetic material shared by people reporting Métis ancestry. Using these data, we thought that this might be a mutation that was introduced into the population around 10 generations ago. But this was very preliminary given that the study had a small sample size. We currently have an analysis, further data from about 60 participants, so quite a bit larger than this original analysis. And we've shared some preliminary information with the community guiding circle already. When ready for publication, we'll be sharing more about how our larger analysis completes the picture that was started with the work that we did here years ago. And this was work supported by the Kennedy's Disease Association, which is the American charity primarily supporting SBMA research. My lab is very interested in biomarkers, particularly looking at RNA. So we have a project within our CIHR project program grant looking at transcriptome analysis of both tissue samples and whole blood samples from patients with SBMA. And additionally, we have plans to do an additional analysis based on ethnicity. And this is to say, is there any possibility that certain biomarkers may be specific to certain populations? So this is a project that's in progress. We have some interim data in analysis from about 35 participants at the moment. We are continuing to collect samples as part of the larger clinical project. I'm expecting results from this study probably in about a year or two that we would be ready to present to the group. once we've completed our recruitment. And our colleagues at University of Alberta are leading our work to look at therapy development for SBMA. And therapy is always the number one, number two, and number three priority for our community whenever we talk to our community guiding circle. And I can completely understand why, because unfortunately we don't have much to offer at the moment. Our colleagues, Dr. Toshi Koda and Dr. Rika Maruyama at University of Alberta, are using novel molecular methods to try and approach this project. So they have a program looking at antisense oligonucleotide therapy. So this is an approach that is used successfully in other neurogenetic disorders. And they've been testing this in cell lines as well as animal models. With great pride to me, one of my former students, Jamie Leckie, is a PhD student in Dr. Yokota's lab right now, leading some of these studies. So I'm very pleased about that on a personal level. And CRISPR activation approach is a bit of a more high risk, but potentially high reward approach to target with specificity the expansion in the androgen receptor that's responsible for the disease. That preliminary study is funded by the New Frontiers in Research Fund, which typically supports more high-risk, high-reward research. And recently, Dr. Maruyama was successful at getting a grant from KDA to address new delivery methods for ASOs. So they're really working hard to find something that's maybe beneficial at a translational level for the future. So that's what I had to present to today, and I'm very grateful for your attention, and I will pass it back to Dr. Osman for any future comments or moderation. Thank you.
Wonderful. Thank you so much. Dr. Schellenberg had asked that I spend just a few minutes sharing some services and supports that are available to Canada to patients who have SBMA and their family members. So I'll go ahead and do that. And then while I'm sharing this, please, if you have any questions based on today's content, based on the guidelines, please put them in the chat, or you can use the Q&A. So Muscular Dystrophy Canada is a pan-Canadian and national organization that we're so grateful that many of you are a part of. Despite our name being Muscular Dystrophy Canada, we cover hundreds of neuromuscular conditions, including SBMA. And so really what I wanted to share is we have been in Canada for about 71 years now, and really align very closely and adhere very closely to the nothing about us without us principle. And so it's really nice that we get to work alongside individuals who have Kennedy's disease and who helped him form the programs and services that I'm speaking to you about. So as mentioned, we cover hundreds of neuromuscular conditions, spinal bulbar muscular atrophy being one of those conditions. And so oftentimes at Muscular Dystrophy Canada, we really talk about where the healthcare system stops, Muscular Dystrophy Canada begins. We know that provincial healthcare systems and the supports that are available can only do so much. And to live well with a neuromuscular condition like SBMA, having those wraparound supports and services are really important. And so with that, I wanted to really highlight that as a member of Muscular Dystrophy Canada, you are eligible to dedicated supports and services. Many of our supports and services really align with our learnings around the costs of living with neuromuscular conditions like SBMA, knowing that there are a lot of out-of-pocket expenses, and that's really where we do have funding for assisted devices, home and vehicle modifications. So as long as you're a registered member of MDC, you'll be able to work with your service specialist in navigating funding for these different pieces of assisted devices, mobility equipment. We also really believe that it's important to offer peer support, and sometimes that is offered in ways of with our retreats. We have these in Ontario and Alberta, so we'll be releasing the dates of our upcoming retreats, and this is open to individuals with different neuromuscular conditions. But at our most recent Ontario retreat in fall of 2025, we had individuals with SBMA and their families join us. Also, we help to connect people with experts like those that are on the webinar today. Finding expertise has been one of our top questions that we get through our research hotline when it comes to SBMA. Many community-based neurologists have shared that they are not as familiar with SBMA, and again, the CMAJ guidelines will be really helpful in making sure people receive expert and also local supports. And I've already alluded to this. We have this research hotline, which really means that if you are a carrier or a person impacted by Kennedy's disease, you have a question about the guidelines or a question about research or about these upcoming treatments that are being studied, about what it means to be a carrier. You can reach out to us at research@muscle.ca, or we can give us a call, and happy to go through the research in a plain language way, answering your questions or connecting you to experts. And then lastly, I just want to mention we do have dedicated system navigators, service specialists who can help you with navigating funding for housing and home modification, transportation, tax credits, benefits, income, finding specialists, community resources, as we know very much that it is beyond just the physical symptoms that can be managed when you have Kennedy's disease. So really did a rapid version of that because I would love to see if there are any questions for our speakers. And I know I see one already. So perhaps I can get started there. Dr. Schellenberg, perhaps you can address this question, which is about, does the guidelines address how carriers can also be managed clinically?
That's a great question. And we do have a section that addresses carriers, but the truth of the matter is we don't have a lot of information to base our guidelines off of or our recommendations for carriers. So there haven't been any studies that look at how to manage symptoms in carriers specifically. So we extrapolate for what we know from men. And so our management would be very similar. So for example, with respect to management of cramps, it would be similar to what we would say for men or for fasciculations or for weakness. But there aren't specific strategies, treatment strategies that are unique for women. We're actually studying this in a little more detail in one of the projects that Dr. Pfeffer mentioned. We're trying to collect data from women who are carriers as well as men, so we have a better sense. And so here would be my shout out that if people would like to be, part of the project, live in Alberta or Saskatchewan, please reach out to your provider because we would love to include people.
Dr. Pfeffer, perhaps this is one you can address, which is, can you explain what a GnRH agonist is as it relates to SBMA? I can read the full
That's a
question.
good question. Yeah.
Someone had read that there is a GnRH agonist that's approved in Japan for SBMA. Is that true?
Okay. Oh, I do not know. It's certainly not, it's not approved here. And in Japan, it seems that they do have a pathway to approve agents with a different requirement for level of evidence compared to what we have here. So certainly we're aware that there's an androgen blocker, for example, that is approved for SBMA in Japan. Maybe we're talking about the same agent here. Oh, we are, yes. So the clinical trial which studied this was negative, formally speaking. But on certain secondary endpoints, it looks like it was possible it could be having a positive effect. And it's a little bit unclear ethically whether it's appropriate to give people treatment with a medication in that situation. On one hand, if there are no other options, it might seem like a good idea to give people a choice to try a therapy, even if it's unclear that it could be a benefit. But on the other hand, if we don't have clear evidence that it's beneficial, we know that all therapies have the risk of side effects and adverse reactions. And certainly there are side effects with androgen blockade. So it's a little bit unclear. I would say at this point we're not, for my part, I wouldn't be comfortable recommending it without clearer evidence. And I think that scientifically we're more likely to have success from a molecular-based therapy, for which there's quite a bit of work in progress in the area and quite a bit of hope for the future.
The next question here is just a clarification, perhaps Dr. Schellenberg in your section, talking about whether SBMA impacts cognition in the brain.
Yeah, thank you. That's a really good question. And the reason I didn't address it is because the evidence for cognitive involvement is very minimal. And so we didn't have a section in our guidelines about that. I don't think that the evidence is there to suggest that it's not definitive enough to know that and to include. There are some trials or some studies that look kind of at brain markers and white matter changes, and there's a few studies. I think it's Manzano and all. It's that diagram that I showed for the multi-system issues. A section in their paper talk about cognitive changes, and really it's not a lot to hang your hat on. So I think at this point, we don't have all the information. This is why it's so important to do research in SBMA, because we don't have all the answers. And I feel like some of this will become more clear over time.
And I guess this is just a term that maybe we all use interchangeably, but the question's really getting at, I go to an ALS clinic. Should I be going to a neuromuscular clinic instead for SBMA management?
I can take that one because I have a special interest in the multidisciplinary aspect of care. So when we set up our ALS clinic in Saskatchewan, we set it up so that we could manage all people with motor neuron diseases, including SBMA. So I see SMA, SBMA, and ALS all in my dedicated ALS clinic. And I think that's a great place to go. And I think if you look at the Canadian providers, I think most people who see SBMA see them in their ALS clinic. So I think that's the right place to be for many people. There may be exceptions to any rule, but I think most of us see people in that environment. But I think the important thing is, as long as you're getting access to all of those various specialists, it doesn't matter whether it's a neuromuscular clinic or an ALS clinic, as long as you have that multidisciplinary care, all those various specialists.
And I know we're at time, but I'll go with this last question. Is there a peer support program available for those with SBMA that really aligns with traditional healing methods or sharing circles or involve elders?
Maybe I should try to take this one on. I don't think there is. We've gotten good advice from our Indigenous community guiding circle, but none of them are traditional healers. They are Indigenous men with lived experience with Kennedy's disease. And as Dr. Pfeffer said in his remarks, they really are looking forward to the time when there will be some actual real testing to do of therapies. That's their primary thing. Of course, I think they're interested in traditional therapies, but there wasn't there just wasn't that kind of experience in the Indigenous community to guide those therapies.
So on that note, thank you all so much for giving us your time and delivering excellent, very clear presentations, and for all the work you've done on these SBMA guidelines. We're really pleased to have a small part in supporting it. Really happy also in terms of next steps, as Dr. Schellenberg mentioned, we will create more patient-facing, again, plain language, and how you can use this as a shared tool with your clinician in managing SBMA. And a recording of today's webinar will be made available, as I know many of you wanted to watch back certain sessions. And if you have any questions once you do that, please send them along, and I'd be happy to connect you to the experts on today's webinar. So thank you all so much, and I wish you all a good rest of your day. Thanks, everyone.
Thank you.
Thanks.